Good afternoon. Today we're going to review GI, differential diagnosis, and abdominal assessment. So before we go into the quadrants, let's review a little bit of possible causes of acute abdominal pain. This is a very common symptom, and sometimes it's acute and severe, and it's almost always a symptom of intra-abdominal diseases. It might also be a sole indicator of the need for surgery and must be attended because if it's not diagnosed properly, it could lead to perforation, ischemic bowel, up to gangrene, and this could occur in as little of as less as 6 hours from onset of symptoms. For example, in certain conditions such as in mesenteric ischemia, which there's interruption of the intestinal blood supply, or in disease process such as strangulation or volvulus, or any type of malrotation as you would see in the explanation of acute abdomen in pediatric population. It is very particular concern as well in patients that are taking any type of immunosuppressant. So anytime you have a patient that has, for example, HIV, or a patient that is on prednisone, a long-term course due to any ischemic, I'm sorry, irritable bowel disease, such as I'm sorry, inflammatory bowel disease, such as the Crohn's disease or ulcerative colitis, patients on COPD or asthma, patients on rheumatoid arthritis or any type of autoimmune disorder that are on immunosuppressants or any type of steroids, that leads to a high risk of perforation. So the pathophysiology of acute abdominal pain is actually based, if you remember in pathophysiology class, there are different type of pains separated into visceral, somatic, and refer pain that we'll discuss in a second. You have to be very attentive to the patient's symptoms, where the pain is located. You would see that if you receive a patient that has a right upper quadrant pain, what are the organs that are located in the right upper quadrant pain? You have the right lower lobe of the lung. So, a patient with right lower lobe pneumonia with diaphragmatic irritation could have right upper quadrant pain. Patients that have any problems in the liver, such as hepatitis, patients that have acute cholecystitis. Also in the right upper quadrant, you have the um, hepatic flexure of the colon. So any problems located in the hepatic flexure of the colon could have a right upper quadrant pain. The part of the stomach, part of the duodenum, the head of the pancreas. So pancreatitis can also reflect in the right upper quadrant, even though it's more common in the epigastric area with radiation to the back. In the left upper quadrant, if you recall, you also have the left lower lobe of the lung. So left lower lobe pneumonia with irritation of the diaphragm can also give you left upper quadrant pain. In addition, you have the body and the tail of the pancreas. You have the splenic flexure of the colon, the spleen. So any splenomegaly or splenic rupture can give you left open quadrant pain, and more other diseases that we'll review later. If it's referred to the right lower quadrant, you have the appendix. You also have the ascending colon. Uh, in the area of the hypogastric area, you have the pelvic organs. So patients that have urethritis, renal colics, problems with the bladder and the prostate, also ovaries and fallopian tubes, and also the bladder. In the left lower quadrant, you have the descending colon. You also have the left ovary. Um, Problems with diverticulitis and diverticulosis will be reflected in the left lower quadrant. So we'll progress into more details of quadrants and disease process, and also the symptoms to differentiate uh, all the diseases. So the most common symptoms of abdominal disease will be, of course, pain. That, if you recall, there is a visceral pain, there's somatic pain, and refer pain. For example, visceral pain comes from the abdominal viscera, and that's innervated by the autonomic nerve fibers and basically responds to sensation of distension and muscular contraction. Um, it's not related to a cutting, tearing type of pain. Is on the contrary vague, is dull, is nauseating, is poorly localized, and tends to be referred to areas corresponding to the embryonic origin of the affected structure. Um, for example, if you have cholecystitis, it might radiate to the right shoulder and to the scapula. Um, the appendix, for example, starts at the level of the periumbilical area and then radiates down to the right lower quadrant. This is basically due to the prior embryogenic origin of the visceral. Um, Somatic pain, on the contrary, is comes from the parietal peritoneum and is innervated by somatic nerves. Uh, this responds to irritation from infectious process, from chemical leak, from fistulas or peritonitis, and other inflammatory processes. And patients complain and characterize this pain as sharp and is well localized. Um, Refer pain is perceived distant from its source and results from, again, convergence of nerve fibers at the spinal cord and due to the embryonic origin. Common examples, I already explained them, that maybe, scapular pain due to biliary colic, or growing pain due to a renal colic, or shoulder pain due to blood or infectious process irritating the diaphragm, for example. Other symptoms of abdominal diseases that we'll explain one by one will be nausea and vomiting, anorexia or changing appetite. That also includes dysphagia, changes in bowel habit, rectal bleeding, jaundice, abdominal distension, or the presence of a mass. It could be pulsatile or not. So mainly three processes produce abdominal pain. It could be a tension of the GI tract wall from a muscle contraction or distension. It could be ischemia, for example, from mesenteric ischemia, or it could be inflammation of the peritoneum. And talking about inflammation of the peritoneum, this refers to peritonitis. And peritonitis is an inflammation of the peritoneal cavity that is the most serious cause and complication of a perforation of the GI tract. um, it could be a gastric ulcer, a duodenal ulcer. It could be any other visceral that undergoes acute perforation. And that, of course, causes immediate chemical inflammation followed by infectious process from a translocation of intestinal bacteria. Also, peritonitis can result from any abdominal condition that causes inflammation. It doesn't have to be necessarily a perforation. It could be a diverticulitis, it could be a pancreatitis, it could be a pelvic inflammatory disease, it could be an ectopic pregnancy, or even acute mesenteric ischemia. Barium, if you give barium to a patient by oral contrast CT with any type of perforation, could also induce peritonitis. So that should never be given to a patient with suggested GI tract perforation. Um, Always remember that peritonitis causes a fluid shift into the peritoneal cavity and bowel that leads to severe dehydration and electrolyte imbalance. And peritonitis can also lead to a pulmonary syndrome that is called adult respiratory distress syndrome, that patients go into a respiratory failure and needs intubation. And also patients can undergo a major complication of kidney failure, liver failure, and even up to septic shock and disseminated intravascular coagulation. So the abdominal pains could be colically, and colic abdominal pain is mostly peristaltic in nature. So it's a tension pain, it's peristaltic, arises from visceral, and is produced by an irritant substance. It could be viral, it could be bacterial, or basically an intestinal obstruction. So if it's referred to an intestinal obstruction, Remember that intestinal obstruction could be mechanical, um, or not. If it's mechanical, it could be related to a tumor. It could be related to a complete arrest of the passage of the fecal matter through the intestine, and it's often associated with cramping, pain, vomiting, lack of flatus, and lack of defecation, which is called obstipation, not constipation. Constipation is decreased amount of fecal matter through the intestine, and obstipation, OBS, obstipation is nothing. Um, the diagnosis is basically clinically and is confirmed by abdominal x-rays, basically a KUB or a CT scan of the abdomen. And treatment basically is fluid resuscitation, nasogastric suction, and in most cases, when there is a complete obstruction, of course, surgery. Mostly the etiology of bowel obstruction. If it's mechanical, it could be related to adhesions, hernias, tumors, or diverticulitis. It could also be related to intussusception or fecal impactation. So, talking about other types of abdominal pain, it could be related to stretching. So, if the patient has splenomegaly or a hepatomegaly or hydronephrosis, just by growing the capsule of the organ by increasing size, could produce this type of pain. So, other types of acute abdominal pain could be related to strangulation of the peritoneum by decrease or impair uh, venous or arterial supply. And this basically is produced by a disease process that you must know is called acute mesenteric ischemia. Very highly missed as diagnosis, and as I said, most of the time the patient has less than 6 hours to recover blood flow. Otherwise, the intestine goes into ischemia and necrosis, and basically this is gangrene. Um, this is acute mesenteric ischemia, which again, it could be related to an embolism or thrombosis, or any type of low flow state. It leads to mediators release of inflammation, as you remember in pathophysiology, all the cytokines and tumor necrosis factor, and ultimately, if there is no recovery, into infarction. The main symptomatology to refresh from patho is the abdominal pain that is out of proportion to physical findings. So basically, the patient is in excruciating, sharp abdominal pain, and when you are going to assess that abdomen, or you start talking to the patient to distract the patient from the actual abdominal assessment, the abdomen is soft, the abdomen is non-tended to deep palpation. So the first thought is this patient is overreacting, and basically is that when it's still ischemic and non-necrotic, um, this pain is out of proportion. Early diagnosis, as you could imagine, is very difficult. But if you think about it, promptly and try to include that in the one of the main causes of acute abdomen on patients that arrived to emergency room or urgent cares. Um, you should do an angiography or exploratory laparotomy. Treatment, of course, is going to be embolectomy and revascularization. And also, if there is already necrosis, resection of the area. Etiologies could be many. It could be related to any type of disease process that produces an ischemic colitis. Um, it could be related to, for example, coronary artery diseases, um, heart failure, patients with atrial fibrillation. So any patient that has any hypercoagulability, such as in atrial fibrillation or cancer, um, and arrives with an acute abdominal pain out of proportion of physical findings, you should rule out mesenteric ischemia because this is a killer. Patients with arteriosclerosis, patients with prior events of emboli, such as a PE or DVT or any stroke, patients with trauma, patients with burn, patients that have gone through coronary artery bypass graft, CABG, patients on cocaine abuse, or patients with high dose of vasopressor support, that have abdominal pain out of proportion of physical findings, you should rule out mesenteric ischemia. Now, patients that are intubated and sedated, there's no way they can verbalize this pain, but you would see that these patients would have abdominal distension, and patients hemodynamically deteriorate quickly. So again, the early hallmarks of mesenteric ischemia is, again, severe pain but minimal physical findings. The abdomen remains soft with little or no tenderness. There's mild tachycardia. Now, of course, later, after 6 hours, as necrosis develops, the patient would have the signs and symptoms of peritonitis, as we will see later. That is basically marked by abdominal tenderness, guarding, rebound tenderness, rigidity, and no bowel sounds. Um, Diagnosis, again, is clinically suspicious, and once you think about it, mesenteric angiography or CT angiography is necessary to clear, or ruled out this disease process that has a very, very high mortality as prognosis. And treatment, again, is surgical: embolectomy, revascularization, with or without bowel resection. And of course, you could give vasodilators such as papaverine, but that's more um, high degree of knowledge when you go into your specialty classes. In addition, of course, you have to put the patient on heparin and bridge the patient to warfarin. Um, Other causes could be, again, as I previously said, it could be related to sepsis, to shock, to dehydration, to herniation, and even into any type of malrotation, which is volvulus. And again, what's volvulus? Is actually a subtype of malrotation in which a loop of the bowel is twisted into itself. Um, of course, that leads to ischemia, and before that, bowel obstruction. So patients would have all the signs and symptoms of bowel obstruction, manifested by abdominal distension. Patients could also vomit, bilious vomiting, until develops ischemia to the affected portion of the intestine. This is very, very common in pediatric population. Now, in addition, patients could have abdominal pain due to inflammation to the peritoneum, and I already explained causes and symptoms of peritonitis. Um, that, if you recall again, is basically rigidity, abdominal tenderness, rebound tenderness as well, and there's no bowel sounds. So when you have that, uh, basically is consistent of peritoneal irritation. Um, Patient, of course, does not want to move. They're still in the position. They're not moving. The pain is poorly localized. It's aching, and due to irritation of the parietal peritoneum. Now, if you do a thorough history when the patient has peritonitis, usually suggests the diagnosis. Um, for example, if the patient has um, epigastric pain that is 2 hours after postprandial, and associated, this pain is burning, and patient with a history has been on either antacids or proton pump inhibitors or H2 blockers, and now the patient comes with a diffuse abdominal pain, um, and patient has leukocytosis, elevation of set rate, patient has abdominal rigidity and rebound tenderness, you have to suspect that this patient has peritonitis associated with most likely a perforation of of a duodenal ulcer. These are the type of pains that I already explained. If you see visceral less severe, it's poorly localized, it's dull, it's aching, it's constant, patient is moving, parietal pain is basically is sharp, is well localized, is severe. Patient has guarding, they have shallow breathing, they lay very still. So when the patient has peritonitis, the type of pain that they tend to have is mostly parietal. Um, Refer pain again is poorly localized, is constant, and is basically distant to the area of the primary problem. So you need to make sure that you ask the patient onset of the pain and duration and timing, because if the pain is sudden, it relates mostly to a more lethal, more acute, more complicated case than if it's gradual or persistent. I'm going to give examples in a second. The pain characteristics, if it's dull, if it's colically, if it's burning, if it's sharp. Because if it's a colically abdominal pain, you might think intestinal obstruction. If it's a sharp pain that radiates to the perineum and the labia, um, and it's also colically, you might think about a possible renal colic. If it's a burning type of pain and it's epigastric, most likely related to duodenal or gastric ulcer. Location, if it's radiating to the back and it's epigastric and it's sharp, most likely related to pancreatitis, versus that if it's in the right upper quadrant and radiates to the right shoulder or the scapula, most likely this is related to cholecystitis. We're going to go one by one into the diseases to do the differential diagnosis in this second PowerPoint, because this class will be divided into two, mostly because the file doesn't fit into YouTube. Now, for example, if it's an immediate a pain onset, you have to think about the worst. Either a perforated ulcer or an intestinal obstruction or rupture of an abdominal aneurysm or colic urethral stone pain or rupture of ectopic pregnancy. Of course, it could be related to cholecystitis or pancreatitis or appendicitis, but you have to think about the worst: a rupture of the appendix, a rupture of an ulcer, a rupture of an aneurysm, because it's something immediate onset. I explained this already about quadrants. Look at the right upper quadrant. If the patient comes with that, you think about either cholecystitis or cholelithiasis, any stomach ulcer. Remember, the head of the pancreas is here, but also this diagram forgot about the lung, the right base of the lung. Patients with pulmonary problems could have abdominal pain. In the epigastric area, stomach ulcers or duodenum ulcers, the body and the tail of the pancreas is there as well. So pancreatitis, cholecystitis as well, hernias. In the left upper quadrant, you mostly have the spleen, of course, but also you could have duodenal ulcers, refer pains from biliary colics, and also the tail of the pancreas is there. Remember that the stomach is basically like this. Okay. In the mesogastric area, you also could have refer pain of pancreatitis, but mostly is inflammatory bowel disease that you have here, or irritable bowel syndrome. Remember that the uterus go down here, so if you have at all these levels, you could have any type of colic, renal colic. Okay. Remember that the hepatic flexure of the colon is here, and the splenic flexure of the colon is also here. Any ascending colon problems and descending colon problems. So at this level, you might have kidney stones, the same here. You would have urinary infection, is the same as here, or any type of hernia. Appendicitis, mostly at this area, but remember, pelvic organs, females and males as well, such as ovaries in both places, such as fallopian tubes, such as bladder in the middle. So urinary tract infection, cystitis, mostly diverticuli, pelvic pain, and here, remember, left lower quadrant pain, diverticulitis. So the main diseases that we're going to talk about is in this area, either duodenal gastric ulcer and pancreatitis, right upper quadrant, liver and cholecystitis, left upper quadrant, you must think about pancreatitis as well. But in addition, spleen problems and splenic rupture. In this area, periumbilical and radiating to the right lower quadrant, appendicitis, and the left lower quadrant is diverticulitis. At all these levels could be renal colics, and do not forget that at the level of the mesogastrical pelvic area, female organs. And here again, look at salpingitis and tubal ovarian abscesses, rupture of ectopic pregnancy. The same here, because at the lower area of the pelvis, you have the female organs. So we're going to go one by one in the differential diagnosis. Okay? So refer abdominal pain if you have a patient with appendicitis. Now, you know that most commonly appendicitis starts at the level of the periumbilical area and then radiates down to the right lower quadrant. But in some patients, for example, in pregnant patients, they could start at the level of the right upper quadrant and even in the epigastric area. So elderly population and pregnant patients could have displaced appendix and also atypical symptomatology. In the gallbladder, radiation to the right shoulder and the scapula. For the renal colic, anytime a patient comes in with flank pain, with radiation to the testicles, to the labia in the female, and to the perineum, ruled out possible renal colic. Rupture of the spleen, patients would have left upper quadrant pain with radiation to the left shoulder. And again, don't panic because we're going to go one by one in the second PowerPoint. So look at the refer pains. When the patient have cholecystitis, they tend to have right shoulder and scapular pain. When the patients have, for example, lung or diaphragm problems, sometimes when the patients have lung problems with pleuritis, the pain could be radiating to the back, to the shoulder, to the neck. In heart problems, to the neck as well. Patients with duodenal ulcer or pancreatic problems, it could radiate to the back. And again, renal problems, patients could have radiation to the perineum, to the testicles, etc. So gradual onset, when you have a patient that comes with pain but has been going on for the past week or for the past few days or for the past 2 weeks, think about less acute, less dramatic cases such as urinary tract infection, appendicitis, pancreatitis, cholecystitis, any hernia, or any mechanical obstruction. So in relation to events, you're going to see in the second PowerPoint when we talk about peptic ulcer disease, and also if you recall in pharmacology and pathophysiology, patients when they have peptic ulcer disease, that's separated into duodenal ulcer and gastric ulcer. Remember that in the patients with duodenal ulcer, they tend to have the pain mostly with an empty stomach that alleviates with antacids and the ingestion of food. And 2 hours after the eating episode, the patients resume to have the pain again. Why? Because this pain is related to the amount of hydrochloric acid that is released when you eat. The hydrochloric acid alkalinizes the pH. The food alkalinizes the pH of the stomach, so the hydrochloric acid quantity decreases, and therefore the patient alleviates this pain. 2 hours after postprandial, the food is gone, The alkaline pH is gone, so hydrochloric acid comes back and the patient resumes having the pain. So the duodenal ulcer is mostly with an empty stomach and is alleviated with ingestion of food and antacids, and the pains come back 2 hours after eating or postprandial. In a gastric ulcer, on the contrary, when the patients eat, exacerbates the pain. Intestinal, patients, for example, with irritable bowel syndrome, when they have defecation or flatus, the pain gets relieved. Uh, if the patient have pelvic pain, sometimes it's associated with dyspareunia, which is this is painful intercourse. Now, let's talk about other symptoms that patients could have associated with pelvic disorders. And these are dysmenorrhea. So dysmenorrhea, you're going to have this more in detail in Women Health, but dysmenorrhea is no more than uterine pain around the time of menses. Pain may occur with menses or is preceded by 1 to 3 days before. Tends to peak in 24 hours after the onset of menses, and basically the etiology could be primary or secondary. It could be related to a structural gynecological disorders due to release of prostaglandin. That's the reason why you could take any type of NSAIDs and alleviates. And contributing factors, basically the passage of the menstrual tissue, or any malposition of the uterus, or any narrow cervical os or ostium, any anxiety, any lack of exercise, many other conditions could exacerbate. Of course, risk factors is if you have an early age at menarche, you might have more dysmenorrhea. If you have long or heavy menstrual period, if you smoke, or if you have a family history of dysmenorrhea. Or secondary dysmenorrhea causes could be related to either endometriosis, uterine fibroids, or could be also due to structural problems such as ovarian cyst or tumor or pelvic inflammatory diseases, etc. Other disorders that you have to think if the patient comes with any type of pelvic disorder, for example, could be related to urinary tract infection or prostatitis, any type of musculoskeletal disorder in the hip, or a hernia, because you remember the colon passes all the way from the ascending colon, descending colon, transverse at the level of the epigastrium, and also at the level of the rectum, and very close related to the bladder. So any you have to remember that any severe pain on presentation that begins 6 to 24 hours from onset, meaning that it's a severe, it's an acute pain in less than 24 hours, most likely requires surgical condition. Most likely this is the perforation, this is a surgical emergency, this is an ectopic pregnancy or obstruction or rupture abdominal aortic aneurysm, intussussection, or malrotation. And let's quickly explain all this. For example, we discussed a little bit on perforation when we talked about obstruction and peritonitis, but ectopic pregnancy basically is an implantation of a pregnancy that occurs outside of the endometrial lining, and they cannot be carried onto term, of course. Early symptoms and signs include pelvic pain, vaginal bleeding, cervical motion tenderness, and it could lead up to shock. Patients with hemorrhagic event of ectopic pregnancy could go into shock, hemorrhagic shock, syncope due to rupture. Of course, you must think anytime a female arrives to you on their childbearing ages, if they still could become pregnant by age and they have an abdominal pain, the first thing you must ask is last menstrual period and do a pregnancy test before you proceed to the rest. So you must do a beta subunit of human chorionic gonadotropin and ultrasonography, or ask last menstrual period And of course, the treatment for ectopic pregnancy would be laparoscopic and surgical resection of this. Um, so we talked about obstruction already briefly, even though we're going to have more detailed discussion in the second PowerPoint. So now let's talk about a rupture of an abdominal aneurysm, or what's the same as a aortic dissection. Again, we're going to discuss it in detail in the second PowerPoint, but basically this is a tear in the aortic intima that separates the intima from all the layers of the aorta, or it could create a false lumen. Um, it could occur anywhere from the aortic thoracic up to the abdominal area. So we're going to concentrate on the abdominal area here. And contributing factors and the major risk factor is hypertension. Symptomatology, if you recall from patho and pharmacology, is an abrupt onset and a staring type of pain. It's not burning, it's not sharp, it's a tearing chest if it's in the aortic chest area. If it's in abdominal area, it's tearing abdominal pain that radiates to the back. Um, Diagnosis mainly is by a CT, and always involve aggressive therapy for blood pressure control and of course surgical repair. Patients sometimes could come um, in shock, so you have to provide IV fluids while the patient is getting ready for um, OR. Another, again, we're going to go in detail in this second presentation. Um, in addition, again, we discussed about the malrotation problems that could also cause uh, um, intestinal obstruction. And this, for example, could be intussusception. Um, it's a type of malrotation, is basically telescoping uh, of one portion of the intestine into an adjacent, causing intestinal obstruction and sometimes, of course, ischemia. Generally occurs between the ages of 6 months and 3 years, and most cases are completely idiopathic. There's a slight male predominancy, so occurs more in males than female. Um, the symptoms, the initial symptom of the child is sudden onset of significant colically abdominal pain that recurs every 15 to 20 minutes, associated with vomiting. Um, the child appears relatively well between episodes, and later, of course, ischemia develops and the pains become steady. The child becomes lethargic and with um, bleeding, passage of current jelly stools, um, fecal matter. There's also a palpable abdominal mass that describes a sausage shape, and this is very typical because it's, intestine basically invaginates into itself, producing a telescoping. That's why it's called telescoping. And when you palpate like a mass with the form of a sausage. Diagnosis, of course, is by suspicion, the same as mesenteric ischemia, but once you suspected, CAT scan should be done. Careful with the barium enema because the patient could perforate, and treatment, again, is surgical treatment. So the rule of abdominal pain is that the further the localization of the pain from the umbilicals, the more likely it is that there is an underlying disorder, meaning that yes, of course, you could have pancreatitis, that is epigastric pain radiating to the back, and but it could be related to mild pancreatitis when the patient has severe pancreatitis, even though it starts with the same type of abdominal pain, epigastric radiating to the back. As the patient develops complications of um, intraperitoneal bleed and peritonitis and even ARDS and respiratory failure and renal failure and liver failure, patients will already have a diffused abdominal pain. So that's the reason why it tells you that the further the umbilical, the more complicated the disorder, and the more probability that there is an underlying catastrophic disorder going on. So now let's talk about overview of the symptoms of the GI. Patients could have, when they have a GI disorder, they could have um, upper GI complaints or lower GI complaints. Upper GI complaints, for example, could be chest pain. Patients with gastric ulcer or duodenal ulcer or even disease process very close to the diaphragm, they could have chest pain. But this type of pain most likely is burning in nature. They could have dyspepsia, which is again heartburn. They could have hiccups. They could have halitosis. They could also have nausea and vomiting. So let's concentrate on the nausea and vomiting and the reason why the patients could have this. So basically, if you recall in pathophysiology, is nausea is unpleasant feeling of needing to vomit and represents awareness of afferent stimuli, basically increased parasympathetic tone. Remember that in GI is completely backwards. The sympathetic relaxes and the parasympathetic contracts. So when the patient has to vomit, the parasympathetic tone has to increase. And also stimulation of the vomiting center is vomiting basically is forceful expulsion of gastric content by involuntary contraction of the abdominal musculature, and it should be distinguished from regurgitation or speeding up gastric content without any type of associated nausea. So ask the patient, is this vomiting is preceded by nausea or not? Because many diseases can be differentiated by just one question. In addition, it could be related to Sanker diverticuli. Patients could regurgitate undigested food without nausea as well. So we're gonna go through that one, that etiology as well. So etiology of nausea and vomiting could be related for example, the most common causes, which are gastroenteritis, any type of drug, or any type of toxin. Um, but also could be related to other disease processes such as bowel obstruction. So in the patient have bowel obstruction, in addition to nausea and vomiting, and this vomiting being bilious in nature, patients, of course, they would have the colicky abdominal pain, the abdominal distension, the tympany, the obstipation. When you do a KUB, um, you might see um, the intestine that has air pattern um, that also has thickening of bowel, and patients, for example, maybe it's not related to um, constipation, but it could be related to a structural obstruction, which is a hernia. So if the patient has, for example, a surgical scar, you might think, oh, there's a possibility of hernia because of weakening of the abdominal wall. In a patient with gastroenteritis, for example, um, they could come with vomiting, but they also tend to come with diarrhea. And when you do an abdominal examination, it's basically benign. Um, Hepatitis, for example, to give another differential, patients do come with nausea and vomiting, but also patients could have anorexia, they could have jaundice, they have liver enzymes elevated, etc. So basically, it's an irritation of the peritoneum from either perforation or not of the abdominal organs. It could be related to obstruction, it could be related to toxin, parasites, or maybe it's just pregnancy. So that's the reason why when patients have these type of symptoms, GI, and the it's a female in childbearing ages, you must do pregnancy test. Um, Another example, if you have, for example, perforated viscous from appendicitis, cholecystitis, or pancreatitis, patients would have the significant abdominal pain besides the nausea and vomiting of the disease process, and also peritoneal signs. Um, Patients could also have nausea and vomiting related to CNS disorders. For example, if the patient has a hemorrhage and besides nausea and vomiting, the patients could have a sudden onset of headache or any type of mental status changes or any meningeal irritation signs. Um, Another example could be related to motion sickness or migraine. So patients could have aura or photophobia. So you have to think about associated symptoms to be able to do the differential diagnosis. So dysphagia or anorexia is another type of um, associated disorder of the GI. Uh, so basically, it's loss of appetite, and it's very vague though. Patients with anorexia could be related to the GI, but it could be related to a systemic condition because patients with cancer also have anorexia. Patients, when they have a sepsis or any type of infectious process in another organ, they tend to have not only malaise and weakness, but also anorexia. So anorexia could be related to GI or not. But dysphagia is difficulty swallowing. The condition basically results from either difficult to transport liquids, solids, or both from the pharynx to the stomach. So should not be confused with any stricture or any mercal diverticuli. We're going to talk about it now in a second. Um, Etiology of dysphagia. So every time a patient has dysphagia, um, think about if it's coming from the oropharyngeal or if it's related to the esophageal area. So oropharyngeal dysphagia is basically difficulty emptying from the oropharyngeal into the esophagus, and most likely results from, um, for example, difficulty in muscle motion, such as achalasia, is not related to and structural damage. It's not related to stricture. It's not related to. It's related to passage. It's related to motion and innervation. Um, Patients tend to have a nasal regurgitation of food or tracheal aspiration followed by cough. And most often, this type of dysphagia and achalasia has to do with neurological conditions or muscular disorders. So, if a patient has oropharyngeal dysphagia, think about a stroke, think about Parkinson disease or multiple sclerosis. Um, Myasthenia gravis, for example, can give you that. Or, as I said, any achalasia, so problem with innervation. If it's esophageal um, dysphagia, even though it could be also a motility disorder such as achalasia, um, it could most likely it's related to mechanical obstruction. So if a patient has had any ulcer gastric or peptic ulcer disease that or GERD that refluxes back into the esophagus and produces a chemical irritation, or even um, Barrett esophagus, patients could have esophageal stricture and dysphagia. Uh, Patients could also develop webs um, or any type of rings or even cancer that could provoke uh, this type of dysphagia. Or it could be psychological, it could be related to medications, or it could be financial. So patients could come cachectic to your institution, clinics, or hospital because they cannot have proper amount of food. Also, changes in bowel habit. It could be related to stressors. So patients having diarrhea or constipation um, could be related to stressors, but also it could be related to um, parasites or any type of toxins. So let's talk briefly about diarrhea. If you recall, diarrhea in pathophysiology uh, most likely is related to infectious diarrhea, secretory diarrhea, motility diarrhea, and constipation. What is constipation? Basically, is that the patient cannot defecate for at least 3 days. So, causes is any acute type. For example, if the patient has a pattern of not defecating more than 3 days, um, and then uses laxatives, is not a major concern as if the patient has a normal bowel habit and suddenly develop constipation, because an acute constipation suggests organic cause, whereas chronic constipation is could be functional, or it could be organic. So in many patients, constipation is associated with a sluggish movement of stools through the colon, um, extensive straining that perhaps secondary to pelvic floor dysfunction, or any type of anorectal pathology that they're afraid to defecate because they have anal fissures or they have hemorrhoids. Um, so anytime a patient complains of constipation, if it's an acute and they don't have the history of being constipated before, think about bowel obstruction. That could be related to adhesions or any fecal impactation, or again, hernia or volvulus. Or it could be related to ileus, patients that have been septic, or it could be related to drugs. Remember anticholinergics, they dry everything. Antihistamines or anti-Parkinson diseases, patients that are on calcium, patients that are in general anesthetics or opioids, chronic constipation, uh, even though again it could be functional in a patient that is more than 50 years of age. Think about adenocarcinoma of the colon. Other metabolic disorders that could produce chronic constipation is diabetes, for example, hypothyroidism, Parkinson disease could produce this. But what you're worried the most is basically the acute constipation. So now, um, going back to diarrhea, since this is a slide related to it, basically remember if constipation is not defecating more than 3 days, diarrhea is having three or more defecations in a day, or stool weight of more than 200 grams per day. Um, Complications may result from um, fluid loss, dehydration, electrolyte imbalances, um, bicarbonate loss, hypokalemia, and also diarrhea could also be related to mannitol, lactulose, or secretory, for example, in infectious processes such as gastroenteritis, patients with cholera, any type of endotoxin, or any type of malabsorption could lead to that. Or because of reduced contact time surface area, such as in patients that have um, laxatives or SSRIs, or patients that are in magnesium containing antacids. So, Shigella, um, for example, if they have diarrhea or if the color of the stool is kind of like clay color, with the absence of bile. Think about possibilities of uh, obstructive biliary diseases. Um, we talked about dysphagia and odynophagia. Dysphagia is basically difficulty of passage of food down into the oropharynx or the esophagus. And we discussed about possibilities of stroke. So when the patient have oropharyngeal dysphagia, so first they can't swallow, they start drooling, or they have nasopharyngeal regurgitation or cough after swallowing, and most likely is related to neurological conditions. Also, there is a disease process that is called Senker diverticulitis that patients tend to regurgitate undigested food. Also, basically, this is an outpouching of mucosa through the muscular layer of the esophagus. So, like diverticula, which is an outpouching of the colon, diverticular of Sanker is an outpouching of the esophagus that could be completely asymptomatic or could cause dysphagia and regurgitation. Dysphagia, again, is mostly esophageal, is not oropharyngeal. Um, Patients regurgitate undigested food. They tend to have aspiration pneumonitis, mostly nocturnal, um, and the treatment basically is surgical. And also esophageal stricture, which also could cause dysphagia. Um, is basically an intrinsic disease of the esophageal lumen that obstructs the passage of food down into the stomach. Um, Most likely is identified by AGD. You have to do an endoscopy to be able to see it. Um, and this could be from radiation therapy, from any type of malignancy, from, for example, if you have candida in the esophagus due to HIV. It could be related to medications. So patients that are on NSAIDs prolonged, they could have this. Now, GI bleed basically is divided of, even though it's not here, I have to discuss hematemesis. So hematemesis is vomiting of red blood and most commonly indicates an upper GI bleed that could be related to peptic ulcer disease or any type of esophageal viruses from liver cirrhosis. Um, Patients could also vomit coffee ground emesis, and when they do that, is basically that the blood has already been digested um, into the stomach acid, the gastric acid content, and the hemoglobin has breaking down the hematine due to the acidity of the stomach. Um, Hematochezia is the passage of gross or bright blood from the rectum. Usually indicates lower GI bleed, but also may result from vigorous upper GI bleed when there's a rapid transit time. Uh, Causes of hematochezia, think first, the most benign is hemorrhoids or anal fissures, but it could be related to tumors or diverticulitis or ulcerative colitis. Melena is mainly black, tarry stool, and typically indicates upper GI bleed. But bleeding from a source in the small bowel or right colon may also be the cause. Um, Now, jaundice is basically a yellowish discoloration of the skin and the mucous membrane. Mostly, this is caused when the bilirubin level is more than 2 to 3 milligrams per deciliter. Um, Mechanism of Hyperbilirubinemia. Um, if you recall in pathophysiology, there is conjugated and unconjugated hyperbilirubinemia. Basically, this is divided into prehepatic, intrahepatic, and posthepatic. For unconjugated hyperbilirubinemia, most often um, the cause is by either increased production, decreased hepatic uptake, or decreased conjugation. So this is mainly any disease process that affects the blood supply to the liver, and that most likely is related to anemias or any type of hemolytic disease. Um, for example, sickle cell is an example of it, or spherocytosis is another one, sepsis is another one. Intrahepatic or conjugated hyperbilirubinemia most often is due to dysfunction of the hepatocytes or obstruction of the extrahepatic bile. So examples of this, cholecystitis or cholelithiasis or hepatitis. And post-hepatic is mostly pancreatitis, duodenal diseases, etc. Abdominal distension. So let's talk about possible etiologies. Um, Causes such as intestinal obstruction that we discussed. Um, Ileus paralyticus is another one. Basically, it's a temporary arrest of the intestinal peristalsis, and this occurs most commonly after abdominal surgery. Symptoms are associated with nausea, vomiting, and abdominal distension. Diagnosis is mostly by X-ray findings and clinical impression. And treatment, of course, is supportive with nasogastric suction and IV fluids. Um, Now, discussing another causes of abdominal distension that we should know. For example, let's talk about cirrhosis of the liver and ascites. Um, Basically, this is free fluid in the peritoneal cavity. This is the most common cause of portal hypertension. Symptoms basically is abdominal distension due to the amount of fluid. Diagnosis is based by ultrasound or CT of the abdomen, and the treatment is basically bed rest, sodium restriction, diuretics, and of course paracentesis. Um, the most common etiology of this is hepatic causes that could be related to portal hypertension due to cirrhosis of the liver or hepatitis or alcohol, but there are also non-hepatic causes, as we know. Um, Having cirrhosis, cryptogenic, could be related to diabetes. It could be related to heart failure. Ascites related to nephrotic syndrome or right-sided heart failure or hypoalbuminemia. Um, in addition, pancreatitis and mixed edema, for example, it could be another causes of abdominal distension could be as benign as pregnancy or obesity, or for example, if the patient has aerophagia. A very good example is a patient on BiPAP, like respiratory support. Now, other symptoms related to GI disorders are, for example, the presence of neoplasms or cancers that we'll discuss one by one in the next PowerPoint, and or hernias. For example, if the patient have abdominal hernia, which is no more than the peritoneal content that is uh, extruded to the outside, and this could be related to the intestine, the omentum, or the bladder. Inguinal, that having an inguinal hernia is no more than either the intestine that comes out through the groin or the scrotum. It could be femoral or it could be umbilical, and or the presence of a pulsatile mass that is one of the symptoms of abdominal aortic aneurysm. Um, Basically, most of the time is asymptomatics. But if the symptoms occur, patients could have a steady, deep, boring, visceral abdominal pain um, that could be felt also in the back, lumbosacral, and patients may or may not have a palpable pulsatile mass in the abdomen. Um, and most of the time, this happens when the aneurysm is more than 3 centimeters. Other symptoms of acute abdomen is tachycardia and tachypnea. Remember that any times there is a decreased blood supply producing ischemia to any organ would have shortness of breath. In addition, there's a lot of leakage of fluid to the outside. The pain causes tachycardia, and dehydration and volume loss also produces tachycardia. And also, do not forget, patients could even go into respiratory failure due to an abdominal process. Causes of abdominal distension that you would never forget if you remember the 7 F's: fat, if the patient is obese, having a uterine fibroid, flatus, meaning that abdominal distension due to ileus paralyticals or bowel obstruction, fluid, ascites, fetus, if the patient is pregnant, feces, if the patient have an intestinal obstruction, or fatal, if the patient have a tumor. Strategies that the patients could develop to decrease abdominal pain: it could be belching, if the patient have a gastric distension. um, Eating, for example, if the patient has duodenal ulcer, they tend to eat to decrease the acidity of the stomach and alleviate. If the patient have any type of bowel obstruction, they tend to vomit to alleviate. If the patients have, for example, pancreatitis, you would see when we discuss pancreatitis that one of the alleviated positions will be leaning forward, exactly the same as pericarditis. If the patient has peritonitis, they tend to be still, they don't move, and they flex the knees. If the patient have appendicitis, for example, they tend to have flexion of the right thigh because the iliopsoas muscle is irritated. Or in diverticulitis, on the contrary, they tend to flex the left thigh to alleviate the iliopsoas muscle in the left because it's irritated. So now let's go through the abdominal examination. You have to, it's a little, it has two processes alternated or backwards as the previous. You always inspect, auscultate, so do not touch the abdomen until you auscultate. Then you percuss, then you palpate. So what are you going to see in inspection? In inspection, if the abdomen is flat, if it's rounded, if it's scaphoid or protuberant, if the patient is obese, if the patient has any scarring or any stria that could make you think about possibility of prior obesity or maybe Cushing, any mass. So an inspection again, stria, any pink purple if you're thinking about possible Cushing disease, if the patient has protuberance, such as in pregnancy. Uh, Another sign, for example, if we talked about pancreatitis, even though we're going to discuss it in the second PowerPoint in detail, would be any signs of major um, complicated diseases such as pancreatitis. Patients, when they tend to have retroperitoneal bleed, they have these two signs, which are gray turning sign and cooling sign. Remember, pancreatitis in pathophysiology is an inflammation of the pancreas causing release of pancreatic enzymes that is most likely, of course, triggered by biliary tract disease or alcohol. But the patients, although tend to have um, abdominal pain associated with nausea and vomiting, and this pain being mostly epigastric with radiation to the back, um, patients could have um, two signs of um, retroperitoneal bleed or severe peritoneal irritation, um, which are Gray Turner sign, which is a chemosis of the flank, or Cullen sign, which is a chemosis of the umbilical region. And again, these two signs, very important to remember, indicate extravasation of hemorrhagic exudate, which is no more than hemorrhagic pancreatitis or hemoperitoneum. This is the cooling sign around the umbilicus, and this is the turning sign in the flank. Now, the auscultation, you're going to auscultate if there's a normal peristalsis, or if there's a hyperactive vowel sounds, or hypoactive vowel sounds, or absence of vowel sounds. Remember, you have to listen for at least 5 minutes in every quadrant to be able to say that there's no vowel sounds. For example, another factor that you're going to look, if you're thinking about the possibility of mesenteric ischemia, uh, most likely there's no vowel sounds. But in vascular sounds, if you're thinking about the possibility of renal artery stenosis, which again is a decrease of blood flow through one or both of the main renal artery or their branches, it could be completely occlusion from an emboli or thrombi, or it could be chronic or diminished flow due to atherosclerosis or fibromuscular dysplasia. The symptoms again is steady aching flank pain or abdominal pain that is associated with fever, nausea, vomiting, and hematuria. But the most relevant factor or history of this patient is a chronic progressive hypertension that is refractory to any antihypertensive treatment and may lead to chronic kidney disease. And when you assess the patient, patients tend to have a bruit. If you're thinking about, for example, liver or spleen rupture, you could have a friction rub, or venous home that is no more than increased collateral circulation when the patients have portal hypertension. Percussion, remember that tympany is presence of a normal percussion sign in the abdomen. So this mostly reflects air. When the patient have fluid, or when the patient have any masses, or for example in the left descending colon, if it's occupied by feces, it tends to be dull. So when you percuss on over organs, over solid masses, over fluid, or over feces, it tends to be dull. So don't get confused by this statement here. Tympany is air. Tympany is air. Fluid, organs, masses, or feces, dullness. Liver and spleen should not be palpable. And if it's palpable, the liver is 10 centimeters in width, and the borders tend to be firm but soft. The spleen, when you percuss the lower interstitial space in the left anterior axillary line, normally is resonant to tympanic. If it's dull, it's because the patient has splenomegaly. And mostly the causes of splenomegaly are autoimmune or related to cancer of the hematopoietic system. Also, when you percuss in the costovertebral angle, if it's tender, patients tend to have pyelonephritis. Or if now you start percussing the abdomen, which normally is tympanic, and there's dullness, and when you tell the patient turn to the side, we're going to see this in the second PowerPoint, turn to the side, and the dullness shift, this is a sign of ascites. Or if you're going to palpate the patient and you produce a fluid wave, this is mostly pathognomonic of ascites. In a palpation, palpate lightly first and then deep, as you recall. If there is rigidity, it's a sign of peritoneal irritation, of peritonitis. If it's a localized rigidity, it's mostly related to cholecystitis, pancreatitis, appendicitis. Or if there is rebound tenderness, which is the same as hyperesthesia or high elevation of pain during light palpation, is a sign of peritoneal irritation. When you palpate deep, you're looking for pain, guarding, or masses. And again, the liver should be regular, should be firm, smooth, and soft. You could do a direct or a hooking maneuver for both, for spleen and for liver. Remember, the spleen is non-palpable, it's retroperitoneal. The aorta is slightly left of midline, and always check for aortic pulsation or if there's any mass pulsating in the abdomen. that could indicate a aortic aneurysm of the abdomen. Also, you could palpate the urinary bladder. Should not be above the symphysis pubis, and if it's above, there is urinary retention or possible cystitis if it's painful to palpation. So additional procedures, again, try to percuss and do the fluid wave for ascites. That is an indicator of either right side heart failure or cirrhosis of the liver or any type of malnutrition or nephrotic syndrome or decreased albumin level. Use a pain scale to assess for pain. And again, look for rebound tenderness. And basically what you do is that you press with your fingers a 90-degree angle deeply and then remove quickly. And if the patient has pain when you remove the fingers, that's called rebound tenderness and produces a very sharp pain, and that's a sign of peritoneal irritation. Other two signs that are indicative of appendicitis, for examples, are the iliopsoas and obturator test. Basically, the patient with appendicitis, even though we're going to go in detail in the second PowerPoint, they tend to have, again, first periumbilical, some patients, such as pregnant, for example, epigastric, that is followed by a brief nausea and vomiting and anorexia, and then the pain shift to the right lower quadrant and increase by cough or motion. Classic signs, though, besides iliopsoas and obturator, you would see that is related to McBurney point, which is no more than a junction of the middle and outer third of the lining of the umbilicus and the anterior superior spine. So basically, an imaginary line that you trace between the umbilical and the right iliac crest, and midpoint you press and release, and the patients would have pain. In addition, patients could have the Robson sign, which is no more than pain felt in the right lower quadrant with palpation of the left lower quadrant. And in addition, patients could have an increasing pain caused by passive extension of the right hip joint that stretches the iliopsoas muscle, and that's the psoas sign, or pain caused by passive internal rotation of the flexed thigh, which is obturator sign. In addition, of course, fever, and unfortunately, these classic findings appear in less than 50% of patients. But when you have them, makes you think about appendicitis, and diagnosis could be clinical evaluation, ultrasound producing or eliciting a McBurney point, for example, and of course, is highly diagnosed with abdominal CT. This is the psoas sign. And as I said, Robson sign and McBurney point, which is more pathognomonic for appendicitis. And appendicitis, before we go into pancreatitis, of course, appendicitis treatment most relevant is surgical treatment. And you have to cover the patient for anaerobic bacteria and gram-negative, which is your any third generation cephalosporin and flagyl, and of course IV fluids. Now, cholecystitis also have a sign, which is called Murphy's sign. But to refresh a little bit, is an inflammation of the gallbladder, most likely produced by gallstone obstructing the cystic duct. Symptoms include right upper quadrant pain and tenderness. Sometimes it's associated with fever, chills, nausea, and vomiting. McBurney point, Murphy's sign, Murphy's sign is no more than deep inspiration exacerbates the pain during palpation of the right upper quadrant, and that halts inspiration. So you tell the patient, okay, take a deep breath, and when you go in to palpate the liver, patients they don't stop breathing, but they halt inspiration because it's really, really painful. That's pathognomonic of cholecystitis. Remember that complications, the most feared complication of cholecystitis is pancreatitis. But even though it's most likely produced by calculus, there is a so-called acute acacus cholecystitis that is most likely present in severely ill patients in the ICU, that most likely is preceded by sepsis, shock, or any type of gangrene. So points to remember before we go into the second PowerPoint. Always, always when you have a female patient with abdominal pain in childbearing age, last menstrual period, pregnancy test or ultrasonography, be consistent with your technique and do a thorough H&P and interview to rule out possible diagnosis based on quadrants and pain location and associated symptoms to avoid unnecessary diagnostic tests. So this is the second PowerPoint presentation that will start in a second. So this is the end of the first.